Byline Audio.
Hello and welcome to the Byline podcast from the Byline Times. The Byline Times is what the papers don't say, what radio doesn't report, and what telly doesn't tell you. My name is Adrian Goldberg. This time, does the health service need more than more money? New Health Secretary Wes Streeting has said the NHS is broken. He's launched a warts and all investigation headed up by Lord Ara Darzi, an independent peer and surgeon. This, as the latest figures show, that 7.6 million people have been waiting more than a year for hospital treatment. As we've discussed numerous times on this podcast, the funding provided by the Conservative government since 2010 has fallen well below what was needed to keep pace with an ageing population. But new Chancellor Rachel Reeves has warned there aren't huge pots of money available to magic up an instant cure. So what can be done? I've been speaking to a couple of people who should know. Later, we'll hear from Lord Victor Adebowale, once reckoned to be one of the most influential people in the NHS by the Health Service Journal. And first, John Ashton, a doctor and for 13 years, the Director of Public Health for North West England. How big does he think the challenge is?
There's a massive challenge with the NHS because more of the same won't hack it. We've got these huge demographic pressures coming of an ageing population, and the NHS is already on its knees. We need a radical change of direction. What does that mean? It means we've got to stop the infatuation with hospitals, and we've got to invest as and when we can in prevention, in very strong primary care and social care, and also rediscovering the link between health and housing, because if we get the right housing investment, and there's a lot of housing investment proposed, then elderly people will be able to stay independently living in their communities for longer and not finish up in a care home, not finish up with several admissions to hospital in their last 12 months of life. So it's a radical change that's needed. Unfortunately, there's a huge collusion gone on traditionally between doctors, politicians and the public to think health is all about hospitals, and it's not. We've got to change the mindset.
So talk me through that then. You talk about an infatuation with hospitals. What do you mean?
Well, since the health service came into being in 1948, the proportion of money spent on health care has got sucked into the hospitals. Even since 2015, a larger and larger proportion of the NHS budget's gone into hospitals and less in general practice. Public health budgets have been shrunk in the last 10 years. So we hear lots of talk about prevention, but the money doesn't follow the rhetoric. And if we look at the differences in life expectancy, but also the period of time that ordinary working people live with long-term conditions and disabilities before they die early, there's huge scope for prevention. We're familiar with many of the factors, with still the smoking levels, which in the middle-class areas are as low as 8% of adult smoking. But if you go to industrial areas of the country, you'll find that still 50% or more of the adults will be smoking. You've got the smoking agenda, you've got the exercise agenda, you've got the junk food agenda, and the commercial determinants of health, which is increasingly what the World Health Organization is talking about, the drivers of ill health that are coming from uncontrolled commercial influences and marketing and all of that. And even down to look what's happened with the gambling industry over the last 10 or 15 years, the way we've got 3 or 4 gambling-related suicides a week now of people in debt and taking their own lives, with this marketing of gambling that's everywhere on the television, late night programs, the programs that young men watch. And we've really got to tackle all of this.
So education is the key. It's clear to me, as you describe it, that this is going to be a long-term process. So in the short term, we are still going to need as many hospitals as we already have, aren't we, for the people who are going to get sick as a result of the systemic issues that you describe?
Well, the immediate thing is that, Boris Johnson promised 40 hospitals. They still haven't built them. But if we do build them, the hospitals tie up the lion's share of the NHS budget. And actually what we need to be spending our money on is really pucker health centre facilities and multidisciplinary primary care, social care in the community. We could take a note from the Finns, where a health centre in Finland includes beds in the community where people can be looked after by their GPs and by the community nurses and not go into hospital, or they can be discharged from hospital to that location and kept integrated in their community. If you go to Finland, you go to Sweden, you go to Denmark, you will see on the high street, along the way from a health centre, there will be sheltered accommodation where people can continue to live their lives as they become older and frail. The nurse can pop in from a health centre to keep an eye on people. And if people are suffering from dementia, they can go into a special care setting just further along the road, and again, where they can be still integrated. Denmark, school children adopt a granny, come in from school on the way home and go and see elderly people. What happens in this country so often, you've got these private care homes, not infrequently in the middle of the countryside, where nobody can go and see them and they just get left there warehoused in the countryside.
So as I understand it, though, you're saying we need much greater education, much greater focus on primary care, much greater emphasis on people exercising, perhaps not just when they're young, but throughout their lives, staying mentally active as well, and resources from the NHS being diverted in that direction. It would take a very brave politician, though, wouldn't it, to say, never mind 40 new hospitals, we need fewer hospitals than we currently have. Is that part of your prescription?
This is the dilemma. We need double running for 5, 10, 15 years while we shift from one model to another model. We had the opportunity with Sir Derek Wanless in 2002. You know, Sir Derek Wanless was asked by Gordon Brown to review the case for an increase in NHS funding from 6.5% to 8.5%, more on the European model. And Sir Derek came back with the recommendation, yes, we could do that. It would be a good idea to increase to 8.5% of GDP, but only if we had the so-called fully engaged scenario and invested the additional money in prevention and in primary care and public health. What happened was we gave a 30% pay rise to consultants and to GPs. I'm a medical consultant. I got a 30% pay rise after the Wanless report. I mean, now all the argy-bargy about medical pay, what's happening is that doctors are wanting to get back to the position they were in after they'd got the 30% for no increased productivity. And the money was also spent on the new hospital programme. It wasn't spent on the things that it needed to be spent on. So there's no money now.
And that double running that you described, John, is going to come at a price. So following the election of Labour, we go into this new era with the taxpayer being taxed at a record level. There appears to be no appetite from the new Labour government for higher taxation. Yeah. And it's a steady as you goes programme in terms of health service funding. So it's hard to see where your revolution is going to come from.
No, it requires a whole system effort. And part of that is really embracing the fact that 80 or 90% of health and social care is done by families, relatives, neighbours, friends. And we need to support that much better. We need to be investing what resource we have got in supporting lay care and self-care. And that's where the digital revolution can come in as well. Because, you know, my parents back in the 1930s, we couldn't afford a GP, ordinary folk. They had a complete medical encyclopedia, which was free with the Daily Express or something in those days, which actually meant that they handled common complaints for themselves. We need to get back to that in the digital age. I've seen it in Finland, where systematically educating the public about managing common conditions for themselves, perhaps with support from the pharmacist, with the chemist, can reduce GP consultations by 25%. You know, a lot of common conditions, you don't need to see a doctor or other health worker if you are your own health expert. But we haven't tried to do that. What we've done, basically, with the NHS to say, bring out your sick, come to us. And then we have this very ambivalent attitude towards people who've got common conditions that they could manage for themselves if they had a bit more knowledge.
In the wrong hands, though, the use of digital technology can be a shortcut to an inferior service, so that, for example, if you have a digital meeting with your GP, that can just be an excuse for the GP not seeing you in person, and it can become essentially a means of cutting costs.
No, I think the concerns about shifting away from face-to-face contacts with a GP to a digital contact is a real one. We saw some of that during the pandemic. And I think we're in the foothills of understanding what that new social contract needs to be between self-care and professionally supported care, and when can you see a GP? Sometimes you think these days that there's three of us in this consultation. There's the patient, the doctor, and the computer, and the doctor's spending all their time playing into the computer and not looking at the patient, maybe not even examining them, when actually examination is a basic part of what you learn at medical school, and I think those skills need to be kept light. But yes, it's important. But we need to discuss these things. The domination of the hospital model is one which can't go unchallenged. When I was regional medical officer up in the Northwest, I used to challenge the Alder Hey Children's Hospital in Liverpool because they used to say they're the largest children's hospital in Europe. And they were proud of it. And I used to say, well, I understand why you're the largest children's hospital in Europe in 1910, when you had lots of people living in slums and had 9 and 10 children, and you couldn't look after a child effectively at home. But not nowadays. Children should only be admitted to hospital if they really need to be in hospital, not because they've got constipation or for some other reason like that.
Yeah, well, that comes back to my point where, never mind boasting about 40 new hospitals, a brave politician might actually say we're going to have fewer hospitals. And instead of boasting that you're the largest children's hospital, you might boast that we're quite a small children's hospital, because that actually is a better sign of success in your health service. What role in all of this does private healthcare have? Because you'll understand that for the Labour Party in particular, that is a very hot potato. And there are those on the left who feel that private operators should have no role within the NHS at all. Wes Streeting has indicated that he's happy to incorporate some private medicine or private practitioners within the NHS, so long as it remains free at the point of service.
Well, over the years that have gone by since the NHS was started, we've seen areas become more the province of the private sector. I mean, you would have had National Health Service glasses after the war. Nowadays, pretty well everybody gets their glasses from a chain operator. We've seen the way the dental aspects has become essentially privatised. And we've got a very flawed model where the market doesn't work. You know, we could train twice as many dentists if we wanted to. They wouldn't be earning the fabulous salaries that dentists earn today, but we could do with having many more dentists. We could do with having many more chiropodists. You talk to anybody in their 70s, 80s about foot care and about the difficulty that they have in getting their feet properly seen to. There's lots of jobs to be created out there, but at the end of the day, what it means is there'll be fewer very highly paid jobs and there'll be many more medium paid jobs. We've got all these graduates, 50% of the population now goes to university, and then we've got graduates doing jobs which are below their skill level. So there's so many things that a government coming in now for the next 5, 10, 15 years can tackle. The important thing is going to be the vision. The important thing is going to be not being a slave to what's gone on before. We've got to stop driving looking in the rearview mirror. What we need to be doing is looking through the windscreen, seeing what's coming down the track, and really getting imagination into policy making. The tools that are available to a government are many and varied. It's not just about individual patient care. I'm a public health person. What we talk about is that public health is the political wing of medicine, and Parliament is the dispensary, because so much of what needs to be done really requires political action, whether it's about pricing, whether it's about regulation. The nuisance that goes on now with the all-night drinking establishments and the violence that carries on in the small hours of the night because people have had too much to drink and they're making their way home. These are all part of a joined-up agenda, which we really need to have. Unfortunately, there's been a very narrow view on what health is, and health's become equated with hospitals, beds, doctors and nurses, when actually it's much broader and everybody has their part to play. But we need health leadership. Wes Streeting has indicated a willingness to look afresh at this agenda, and let's hope he's able to follow it through.
John Ashton talking to me at the Byline Festival at Dartington Hall, where I also spoke to Lord Victor Adebowale, a crossbench peer, chair of the NHS Confederation, but speaking here in a personal capacity, and a voracious listener to this podcast. Does he think the NHS needs more than money?
Yeah, it does. It does need more than money, yeah.
What does it need, Victor?
It needs leadership. It needs a change in the culture. It needs some TLC, tender loving care. It needs redesign. I hesitate to use the word reform because often when you use the word reform, it usually is translated by people as restructuring, and we've had enough of that. But it does need reform, and it needs to be a political priority beyond health. So we need to be a health-creating nation, not just an NHS nation.
As part of the conversation at the Byline Festival, the point was raised that until 2010, the NHS was performing reasonably efficiently.
Very well, yeah.
In the years since then, the years of austerity, the performance of the NHS has declined, corresponding to the reduction in real terms of funding on the NHS. So why isn't it as simple as restore the funding to 2010 levels and you'll have an NHS that's as good as it was in 2010?
Because in 2010, they didn't just drop the money, they also changed the way that money was used to suit the circumstances then, which are not directly dissimilar than they are now, and certainly in terms of the waiting times. But since then, we've had COVID, we've had a massive increase in demand, and we've got a workforce challenge. Now, I'm not saying that the NHS doesn't need money, it does need money, but it also needs to change the way in which it operates, because we need to move the demand curve away from just hospital care, acute care. We need to be doing much more preventative health care, and we need to be doing much more health creation as opposed to just waiting for people to fall off the end of the cliff. Not only is that a more cost-effective way to run the NHS and social care system, which we need to talk about both things, but that's what people want. Nobody wants to go to hospital, right? So I'm not saying we don't need any money. We do, but we also need to change the way in which we actually run the NHS.
I spoke to John Ashton, and John, as you'll know, is a former Director of Public Health in North West England and occupied other senior positions within the NHS. And he talked about being much more proactive in terms of health prevention and so on.
Yeah.
But to initiate a programme of illness prevention, that's going to take maybe 10 to 15 years to work through. So that's going to be a significant upfront investment. At the same time, I was going to say at the same time, you've still got to maintain the NHS on its current level.
There are some tried and trusted ways in which we could improve health. So, for instance, alcohol pricing, sugar tax, fat tax, actually. When we stopped smoking, for instance, that was a major intervention in health, which has saved lives and saved money. So there are a number of things that could be done that would actually start bending the demand curve at very little cost. In fact, at no cost, really, other than to you if you want to spend money on lots of alcohol. And the argument that's been used against those things, the same arguments that were used against smoking, for instance. I mean, one of the good things that Rishi Sunak did, but then didn't do, was his smoking ban. The idea that we'd end up with a non-smoking generation. I think it was a brilliant idea, and then it was basically lobbied to death. But those sorts of things save money, they save lives, and they bend the demand curve away from expensive illness.
So you're talking about using the tax system, for example, to price out more harmful foods, heavily processed foods, for example.
Absolutely, yeah. So what we need generally is a health in all policies approach. So the government, all its policies, doesn't matter whether it's levelling up housing, should all contribute to a healthier nation specifically. So if you want to change planning law, you should be saying how that law is going to improve the nation's health specifically. If you want to do transport, how is that going to improve? So every policy contributes to health. And that's how you start to bend the demand curve. Then you need to look at the incentives within the NHS so that we're actually incentivising prevention, public health, social care, as well as acute hospital services. So that's within the same funding envelope, but just looking at what we incentivise, how the money flows, how the priorities flow, so that we're getting more value for the money that we actually spend on the NHS. And we need to spend more money because at the moment we've got a £14 billion capital shortfall on the hospital estate. And I've been to some hospitals that are in terrible conditions and need money spending on them now.
We're told that money is not there. Wes Streeting, the new Health Secretary, has said that the NHS is broken, but there are not significant sums of money available to repair it.
I mean, I think he's been honest, frankly, and I think you can't solve a problem unless you're willing to accept there's a problem.
And so you think it is broken?
I think it is broken. I think it's in a dire state, and I think we need to be honest with the public. We need to be absolutely honest with them, and then we need to start fixing it. And there is some money being spent on the health service, the dentistry, the mental health, which I think they're all good preventative spends. We know that people with mental health challenges tend to die 20 years before everyone else. We know that mental health drives demand on physical health services. So to coin a phrase, every little helps. So I'm not going to knock it.
And these are the sums of money that are
the first
identified within Labour's manifesto as their immediate priorities.
Yeah. And I kind of think we can all argue it's not enough, and I would argue it's not enough, but it's a start. And actually, there's something about not doing everything everywhere all the time. Starting with what needs to be fixed now, getting it fixed, seeing the return on that investment, then investing more. And it's that kind of step-by-step approach that I think we need.
You've talked about the problem of social care, and successive governments have grappled with this problem. We've got an ageing population, people who need perhaps not full-time care, but they need some kind of health intervention in their later years. And whichever government has been in power, one way or another, they've all fudged social care. How do we deal with it without spending a lot of money? Again, it seems to me that money is a significant part of that.
Yeah, I agree. I think the workforce issue, so there's been work done that did show, probably 2 years ago, that just increasing the hourly rate for social care workers would actually increase the social care workforce, which we desperately need to do. And if we did that, we'd start breaking up the blocks because we've got a stock and flow problem. There are too many people in hospital who don't need to be there because we haven't got a social care system. If we had the social care system, we could move those people out of hospital, and actually that would reduce the costs and improve health. So there are some things that we could do, I'm going to say a couple of billion, quite quickly, that would improve and would actually save money and save lives. So I hope they do look at that, and certainly what I'd be lobbying for. But then I think there needs to be an immediate attempt to get cross-party, and we nearly got there in the Andy Burnham. We nearly got there, and then there was a political rush of blood to the head that involved, I think it might have been the Conservative Party, talking about a death tax and all this nonsense. And we are going to have to say to people that if you want to be looked after in your old age, two things have to happen. One, we have to start paying for it when you're younger. And two, you can't necessarily die with all your assets intact. That's because, it's just me personally, I don't see the point of dying with a £2 million house badly, but not being able to get the social care that you need to live until you die. So there's got to be a deal done with the public about what it costs before we spend the money. But I think generally the public can see that that's a good way to spend public finances. Nobody wants to live in agony and then die. I mean, it doesn't make any sense.
Do you think that the NHS in the form that we have it now, which is still essentially the NHS in the form that we had it in 1948 when it was created, do you think that is sustainable in the long term?
Yes, absolutely. And I really rail against people who start this debate about the NHS. And I'm sure when I open up my social media, there'll be people saying to me, Victor, the problem is we need a completely different model. Look at what they do on the continent, or look at America. And I usually point out that all the analysis of what those health systems do tell you two things. One, they spend more per capita to start with. Secondly, the cost of the administration of those systems is prohibitive. And thirdly, they're not as efficient as what we do, which is NHS free at the point of care. And by the way, we just need to point out that it's not free. You do pay for it. It's just free at the point of care. right? And the beauty of the NHS system is this. You, Adrian Goldberg, your health risk is spread across 59,999,999 other people, right? That's what the NHS does. It spreads your health risk because you don't know what's going to happen to you in the next minute, right? That risk is spread. That's why it's so cheap, actually, about £4,000 a person. If that wasn't the case, you would carry your health risk on your back. If anything happened to you, it'd be on you, Adrian Goldberg, and you would have to pay, and you would pay whatever some private sector company wanted to charge you, right? And that's why the NHS is so beautiful. It's about shared risk.
And you made the point, I think, in the conversation at the festival about the fact that in 1948, when the NHS was created, the level of debt in the country was greater than it is now.
Absolutely. Dwarfed the current debt burdens. But at the moment, the political weather mitigates against making those kinds of bets, frankly, after Liz Truss. The markets are still jittery. And so we have to work within the current realities. But what it shouldn't do is dampen our enthusiasm, our positivity and our optimism for the NHS and our commitment to health free at the point of access. That is absolutely the central point, the gift. And that's why other countries look to us for inspiration.
In that, you're talking about a policy which would unite the Labour Party, the Conservative Party, even Reform. The NHS free at the point of service. But within that, talking...
Not sure about Reform. But
No. Well, Reform have said free at the point of service. But the point of variation is potentially that of the role of the private sector. So, again, if we're asking this bigger question, does the NHS need more than money? Is there a greater role for private sector in the NHS or a reduced role?
Yeah, I get a bit weary of this notion of privatisation or not privatisation. I know that's not directly what you're asking, but to be honest, and it's where I agree with Wes, if you're ill, most people don't care where the cure comes from, as long as it's free at the point of access. The NHS has used the private sector since its inception. The way in which we contract with primary care, they're all private. So I don't think that's the issue. The issue is, how do we contract with the private sector? How do we ensure we get value and high standards? That's the issue, right? And I was very concerned during the COVID period that our contractual capacity and competency basically just fell off a cliff. And we can't continue with that in mind. So I'm all for using the private sector, but let's make sure we get value.
Yeah, Alan Milburn, who was Health Secretary under Tony Blair, used spare capacity in private hospitals to drive down waiting lists at the start of the Blair era. So that, you could argue, is a big tick in the box in terms of private sector involvement in the NHS. On the other hand, you look at the way in which PFI operated and private companies set out to, it seemed to me, in some cases deliberately rip off the NHS, these ridiculous charges for changing a light bulb. We obviously had the rip-off of PPE in some cases in terms of contracts there. So there will be people listening to this who just say, look, over time, the private sector has proved that it can't be trusted to work efficiently and reasonably with the NHS.
Well, that's why I say we've got to ensure that we have value. The case of Milburn's, I think, perfectly appropriate move to use the private sector to drive down the waiting list was very much argued against by people in the NHS. And he went ahead and did it. You know what? We actually reduced waiting lists, right? We actually did reduce waiting lists. And then you give an example where the private sector has been poorly managed and in cases has ripped us off, which is why I say we've got to ensure that we have the skills to drive value. It's not an argument against the private sector. It's an argument of having proper skills within the Department of Health and in NHS England to manage those contracts appropriately and to be really clear about where they will add value and that we get that value, we get the return on that investment. That's what we need to be doing. I mean, I've read some of the Public Accounts Committee reports into the PFI and it makes painful reading that we were ripped off and people are still earning money to this day from PFI contracts they did they weren't all like that, but too many were. I would argue for much more transparent public scrutiny of the principles driving some of those contracts before they're put into the market. So you don't have to give away commercial secrets, but you're just clear about what are we trying to do, how are we trying to do it, what are the incentives within the contract, make those really public so people like you and others can examine them and go, well, there might be some weird behaviours generated if you do this. And we do that before we contract with people, and we make those private sector companies transparently accountable once they've got the contract for their performance, their outcomes, and indeed, I don't see why they shouldn't be accountable for the profit margins. So they become services to the public and accountable to the public for the duration of that contract. What's wrong with that?
Are you broadly optimistic about the future of the NHS?
You know, I sit here, 62-year-old bloke, in good health, having a chat with you, which I got to be honest, I'm a fan. I mean, I just got to say I am a fan. I listen to your podcast, and I just consider myself far too lucky to be pessimistic. I think the NHS is one of the best things that a country has ever done for itself. We actually invested in ourselves. We bet ourselves. Let's not start winding that back. Let's keep going.
Lord Victor Adebowale. And before that, we heard from John Ashton. This episode of the Byline podcast was produced by me, Adrian Goldberg, and Phil Driscoll. My thanks to him. Before we go, just a reminder to head over to bylineaudio.com, where you can catch our full range of podcast offerings, including Utter Bollocks with Otto English and John Mitchinson, myth busting at its finest and funniest. You can get extra content and an ad-free version of this pod by becoming a premium member. For full details, head over to bylineaudio.com. I'll see you again very soon. Thanks for listening. Bye now.
Byline